So yeah, look, I'm going to be just quickly run through some of the conservative management for FAI. What we're going to look at is just what is FAI, and it's been explained a good bit already. Some signs and symptoms that we would see in clinic, clinical assessments, some rehabilitation strategies that you can adopt, and then management going forward. So FAI, as we know, it's a movement disorder of the hip that results in a triad of symptoms, clinical and diagnosed through morphological change with X-ray. It represents abnormal contact between the femur and the acetabulum, which results in deformity of a cam and pincer and then also soft tissue injury. So the cause of FAI, still really the jury's out on this. Is it nature versus nurture? It's probably a combination of both, where you have predisposition to have either over coverage or under coverage of the hip, then is exposed then to environmental factors such high impact sports such as GAA. Therefore, the link between high intensity participation at an adolescence and the onset of FAI is under investigation. So what can we do? This is something I suppose that when often enough when patients get to us, it's nearly too late. They come to us when the condition is chronic or when they've kind of been to 4 or 5 or numerous healthcare practitioners and have failed each time. Screening and routine screening is something I'm involved with at an underage development squad back in Waterford. And it's something that we do kind of routinely twice a year. It's just a simple range of movement test and then also a kind of quick questionnaire. If they are, or if there is some indications that they may be exposed to kind of having over coverage or having a hypermobile hip, it needs to be monitored and it needs to be continually monitored throughout their development. We need to be aware as well, especially of training loads through maturation. And especially with multi-sports, because the dual sports, we can't really stop it at underage. You get kids that are playing, because they've an athletic ability, they're playing hurling, soccer, football, rugby, and everything else that they're asked to. So something that needs to be looked at. Some signs and symptoms that we typically would see. So a reduced range of movement, not always, as we were saying, with a hypermobile hip, but typically with flexion and internal rotation. Post-activities stiffness is the big one, and is where you'll get an athlete after they play a sport or a match that evening very, very stiff with their hip, not muscle soreness, but joint stiffness from an increased loading of synovial fluid in the joint. Catching, clicking or giving way, trouble sitting or standing, and that's the differentiation between people with over coverage and under coverage, where you'll have the people sitting down will be over coverage, and then the people with standing should be, say, keep shuffling around. It's that's because they're loading maybe 10% of their body weight on the outside of their acetabulum and therefore kind of squashing their labrum that's already inflamed. We also look at if there's a history of extra articular pathologies, people turning up with osseous pubis, lateral hip pain, repetitive groin strains. My one piece of advice is just really always check the hip. Clinical assessment, and this is where we kind of, you have to be quite quick in your diagnosis, not diagnosis, but your decision whether if somebody has been to 4, 5 or 6 different healthcare practitioners and they're coming to you from a long-standing point of view, is it something that you should be considering conservative management, or is it something that you need to be getting an orthopedic referral on? You need to be able to differentiate, and because the source of symptoms or the area of pain is not always the source of symptoms. Propagation tests, as in Federer and Fabers, will show you if there is a concern with the hip. You look at gait analysis, pelvic position as well, especially with anterior rotation, can often close down the anterior part of the hip. And then muscle strength, weaknesses and imbalances. If tight anterior chain, you get a slight translation of the hip joint forward, loading up the anterior hip, again, which causes dysfunction and pain. Diagnosis, this comes from the Warwick Agreement, it came out in 2016. So you need symptoms, you need clinical signs, which we'll be all able to do anyway, but then also the confirmation by X-ray for morphological changes, which is, you can see the cam and pincer there. The acute phase of rehab for me especially, it's reducing inflammation is key, and that's through kind of load modification and also possibly getting the player or athlete onto a course of anti-inflammatory medication. You need to restore the muscle tone and free range of movement. And what I mean by free range of movement is throughout that range of movement test, you're looking for the end field. You're not looking for, if you feel that end field is hard and you've got a bony block, you shouldn't be trying to stress that. You're not going to get any more out of it. So again, your end field, if you are looking to restore range, needs to be soft. Addressing muscle weaknesses with the large prime movers and also the deep hip rotators. And then reducing and setting expectation. It's going to be 3 months minimum. Sometimes that's hard to hear, and there are certain players or athletes that you can continue to play once you modify their load, However, 3 months is the kind of holy grail for me anyway. As the rehabilitation progresses, we look at gait re-education, so lots of landing, pivoting and turning, making sure they can do that without pain. We increase the endurance of the athlete and their agility, so if you can look at maybe low non-impact weight-bearing exercises at the start and progress as able. Again, progressing deep, the strengthening of your deep hip rotators. Pelvic control is massive, and then looking to more sport-specific movements, making sure that you can do that without pain. We also need to develop then a patient-specific management program. Okay, that's not there. I knew it was going to be me. Your management program is a couple of things. You need to be able to kind of reduce the loading of the hip. That's huge. So any provocative movements you need to take a step back from. You need to be able to look at the athlete from a perspective of reducing fast agility drills within their training and match time. So lots of kind of fast rotation drills, Monday, Tuesday, Wednesday, Thursday. It doesn't work. You need to be able to, I'm trying to remember the slides now. Modify training load. And, it's a management system. It's not a cure. That's the one big thing I suppose we can take away from this. If somebody has morphological changes and they have had, labral tears, it's a bony structure. We're not going to take away that with physiotherapy. So it is about management going forward and them understanding the necessary triggers, whether it's a restricted range of movement or pain, that once that starts to set back in, they need to kind of reset, unload, and get back to where they were at the start of the rehab.